Thank you for that introduction. Doc, you may not know this, but Dr. Chudler is one of the preeminent neuroscience educators from kids up to not kids. And so it's an honor to sort of be here to do something that's related to neuroscience and neurology. So, I mean, this is a topic that's very important to me. I see patients every week with in the memory clinic, and I think it's just an important conversation that we need to have more of, because I think all of us, I would venture to say, are touched in one way or another by dementia or Alzheimer's disease through different family members or friends. A couple caveats before I get started. What I'm going to say are my views, and they don't represent the UW or OHSU. I don't have any conflicts of interest disclosures. I'm going to mention a few medications, but I've never received money from a pharma. And what I'm going to talk about is educational. It's not medical advice. So kind of with those things out of the way. Wonderful, thank you. So I thought I'd start with this. So the Alzheimer's Association, which is a wonderful organization, but nationally and in Washington, puts out a graphic every year with a bunch of really I'm going to stand here. A bunch of really important and sort of provocative facts about Alzheimer's disease and dementia. So 1 in 3 seniors will die from Alzheimer's or dementia. It kills more than prostate cancer and breast cancer combined. There are 11 million people in the U.S. who will provide care for people with Alzheimer's disease and other dementias. And even though we've done a pretty good job of starting to reduce the risk of heart disease and other cardiovascular causes of death, Alzheimer's deaths and dementia deaths have increased. The economic costs, I think, this is something that people who have a personal connection to dementia are well aware of this. But I think when those costs are compounded across society, the economic costs are staggering, right? And a lot of this is unfunded caregiver time that could have gone into doing other things, right? And then a fact that I'll come back to later is just the risk for if you get someone who's 45 and you ask how likely are they before the end of their life to get Alzheimer's disease, it's 1 in 5 for women and 1 in 10 for men. So this is a really important and difficult problem for us individually and society wide. I just wanted to highlight here that, and maybe you've noticed this in my speech, but I've talked about both dementia and Alzheimer's disease, and even in the graphic here, sometimes they are giving statistics for Alzheimer's disease, and sometimes they're giving statistics for dementia, and part of this is. And this, I think, leads to a lot of confusion about is Alzheimer's disease just the same thing as dementia? I think sometimes we use those terms interchangeably, but they're not. From a scientific and medical standpoint, they're different, right? So dementia is the name for some sort of cognitive decline from one's baseline that affects one's daily function in some way. And there can be different causes of that. And Alzheimer's disease is by far the most common. So 2/3 of dementias end up being caused by Alzheimer's disease. But there are lots of other kinds of dementias that are worth paying attention to. So there's dementia that can be caused by large strokes or someone who has a bunch of little strokes. There are dementias in the there's dementia caused by the Parkinson's disease family. So whether that's Lewy body dementia or Parkinson's disease dementia, it's kind of a spectrum. There's frontotemporal dementia, normal pressure hydrocephalus, which is characterized by excess fluid in the brain. There's traumatic brain injury. Different kinds of neurodegenerative diseases like Huntington's disease can be associated, often are associated with dementia. There are alcohol-related dementia, and there are a number of others. In terms of sort of the sort of how common this is projected to be over the next 30 to 40 years, I think this graphic is really telling. So the purple line is the number of people who in the U.S. who are going to get Alzheimer's disease over the next 40 years. So in 2020, it's about 6 million people, and by 2060, about 14 million people. And in part, this is a positive story in that the single biggest risk factor for Alzheimer's disease is age. Is advanced age. And so part of what this figure is showing is that we're living longer. And so, reductions in heart disease are a big part of this, and reductions in smoking are a big part of this. But it still tells us that our society is going to change in substantial ways. This, you might have seen on that first graphic, this sort of points out the difference between the risk for men and women of Alzheimer's disease. So there turns out to be twice the risk of Alzheimer's disease for women than men. And we don't really know why. There are a number of different theories about this. Part of it is probably explained by women on average living longer, but I think that's probably not the whole story. But there's a good bit of research on this. There are a number of different risk factors for Alzheimer's disease, and I'll get back to some of this toward the end of the talk when I talk about prevention. But there's, depending upon kind of who you ask, there's about 12 or so kind of major risk factors, and I thought I'd just kind of quickly go through some of them. So one of them is decreased physical activity, particularly in midlife. In obesity in midlife. Curiously, that obese or higher BMI in older adults tends to be a protective factor. So we don't really fully understand kind of why that is. Depression is a risk factor for developing Alzheimer's disease. It also, as we'll see, kind of complicates the diagnosis of Alzheimer's disease. Social isolation is also a risk factor for Alzheimer's disease, as is increasing evidence. You may have heard some of this in the news about the role that hearing loss plays in people going on to develop Alzheimer's disease. People who have diabetes, high blood pressure, cholesterol are all at increased risk for Alzheimer's, and smoking and alcohol use also increase risk. And poor sleep, another one of those things that I think wasn't fully recognized 15, 20 years ago, but this is, and we'll get back to this later, this is also an important risk factor. The green boxes, or the orange boxes here, represent modifiable risk factors, whereas the ones in pink are things that we can't really do anything about. We're all going to age, and age is going to be a risk factor for Alzheimer's disease. Having a family history it puts people at risk of Alzheimer's disease. We generally think about that as having a brother or sister or a mom or dad who had Alzheimer's disease. Kind of the farther you get out from what we call first degree relatives, the less clear the genetic link is between an individual and their family members. And then there's some genetics. that there's a genetic component to Alzheimer's disease that's an important and evolving story, and I'll get back to that. Um, I put this slide in here just to, and I think many people are probably aware of this, but Alzheimer's disease is a progressive, and often a slowly progressive disease, and we now think about it starting in a preclinical stage in which there are probably brain changes going on before anyone has any symptoms of memory problems or other kinds of thinking problems. And then the next stage is what we call mild cognitive impairment. This, again, is a diagnosis that didn't really exist 20 years or so ago, and is now sort of part of our understanding of the disease of Alzheimer's disease. So mild cognitive impairment is the developing mild symptoms of memory loss, of language problems, of decision making, of visual spatial skills, but that don't clearly affect daily life. It's a bit confusing because kind of what it means to affect one's daily life is a bit ambiguous, and so different people kind of understand that differently. And then there's sort of mild, moderate, and severe. There are other ways of sort of characterizing the different stages of dementia or Alzheimer's disease. I think this is this three-pronged way of doing it, I think, is the most helpful. And it's whether or not you're starting to have some problems with daily functioning, a pretty good amount of problems with daily functioning, or you're really needing a lot of help with most of your kind of daily functioning. The blue line here is if you can think about this superimposed onto the last figure, what this is showing is that what's happening during that kind of preclinical stage is they're starting to develop certain kinds of proteins that start to accumulate in the brain, whether or not that's what we call amyloid or tau. And we can see that they're starting to accumulate in the brain even before anyone has any symptoms. But then they continue to accumulate as people start to have symptoms, and then just continue on throughout someone's life. I wanted to just talk about, use this figure to sort of talk about what is the process of diagnosis and treatment. Because it's I think it can be a confusing and a discombobulating experience for a lot of people as they go through it. And I'm going to start with, so the first thing that someone does is they or someone they live with or interact with notices what they think is a change in cognition, and that's what brings someone to medical attention, often to a primary care provider, sometimes directly to a specialist like a geriatric psychiatrist, a geriatrician, or a neurologist like me. And what we start with is just kind of getting a history from the patient themselves and what they're noticing. And they may not notice anything, and their family member may notice something. So having a family member come during an evaluation is critical, because sometimes you don't remember what you don't remember, and so it's always nice to have a second set of eyes. We review sort of the medical history because there are certain things that can certain medical conditions that can cause cognitive problems, whether or not that's a history of stroke or a history of traumatic brain injury or other things. We review medications because there are medications that affect our cognition, right? So if you take a cold medicine, for instance, that knocks you out, right, what that's doing is affecting your brain. And so it's important to sort of pay attention to medications that can affect cognition that may not have affected cognition when someone was younger, or when one was younger, but as one's brain ages, they can become more sensitive to some of these medications. I'll ask about family history as I talked about before, and then I'll sort of delve into a history of alcohol use, tobacco use, and other um, and marijuana use more recently. Um, you know, part of so besides that, I'm trying to figure out is are the things that the person is coming in with or the family member is coming in with, does that represent something that is just sort of part of the aging process, or is it something that maybe is a little bit more worrisome? And these can be really hard to tease out, but there are often some clues, right? So for new memory problems, what I'm really interested to know is, are these really new? Um, are they are they a decline from how someone was a couple years ago or 5 years ago? Um, Examples here would be repeating the same question multiple times without remembering that they had already asked that question. And starting to rely on family members to do things that they didn't really have to rely on them to do before. Some difficulty with planning or problem solving. So, putting together, fixing things around the house might be difficult, and for someone who was always very, very handy. That might be sort of a tell for me. And new problems with previously easy tasks, like going to the grocery store that we've been going to for 20 years, right? That starts to worry me. I'm less worried about, we went on a trip to the Washington coast. We've never done that before, and it got turned around. It's like, well, that's less concerning to me than something that's pretty overlearned. Confusing time and place, so what we call orientation, right? So being off by, eh, depending upon one stage of life, and if one is, in the workforce, right? The remembering when Sunday is and when Monday is really matters. When you're out of the workforce, yeah, right, and so so knowing the exact day or which day of the week it is, I tend not to be super concerned about that. But when there are sort of kind of breaks in time and sort of thinking that something that happened last month when it actually happened 2 years ago, right? Those sorts of things sort of worry me. Um, Difficulty sort of tracking conversations, like just having a hard time, as a conversation is going on in a social situation, and just having a hard time sort of following the conversation, and that is right is a little bit more worrisome to me. And sometimes how that manifests itself is that someone might sort of start to retreat a little bit from social situations, and sometimes it's hard to tease that apart from whether or not it's because of because of that, or because one is depressed, or not feeling well, or doesn't like the persons that they're being asked to be around. So sometimes it's hard to sort of tease those things apart. Misplacing objects, right? This is something that I think we're all sort of aware of. I misplace objects when my mind is elsewhere, right? So it's, I think we all sort of do that. But I think, you might think, well, when I find it, if I ever find it, I think, oh, that's right. I was down in the basement doing this, right? But not remembering like how it got there, right? That then there's this gap in memory that makes me a little bit more worried. Um, so this is just to sort of reiterate that there's sort of mild, moderate, and severe stages of disease, and there are symptoms that tend to kind of clump together in each of those phases. And so, usually someone is coming to me in the very mild stage, and so I'm trying to tease out is this normal changes of aging, or is this something more than that? But sometimes people come in at more advanced stages, and so it's important to have a sense of what would be typical, especially what would be typical of someone coming in with a more moderate stage that just got missed in their diagnosis, which does happen. The So after I do some blood tests um, to look for things that can also cause memory problems. So low vitamin. So when someone first gets an evaluation for memory problems, they'll get some vitamin labs. They'll get some thyroid labs. They'll get sometimes some infectious labs, just to make sure that there aren't these other things that could be causing memory problems. So part of my job is trying to figure out, like, um, could there be some other reason that someone is having memory problems? And I say memory problems, but I should clarify that's I say memory, but it's really standing in for all these kinds of thinking problems, right? Whether it's language problems or visual spatial problems or decision making problems, because not everyone who has Alzheimer's disease um, will start with having memory problems. They can start with some of these other problems as well. And then what we do is a cognitive test, a cognitive screen, and there are different kinds of these, and different clinical providers are more comfortable with some than others, and some are more sensitive and specific than others. Um, the one that I like, and there's a common one, is called the MoCA, or the Montreal Cognitive Assessment. And I just wanted to sort of put up here, and sort of you can see in the black boxes are the different areas of thinking that are trying to be screened in this larger tool. So they're trying to test for visual spatial skills. Is someone having problems knowing where things are in space, right? Are they having problems with language, whether or not that's naming animals or repeating sentences, or coming up with a list of words. There's also memory testing here. There's also attention and concentration. So this is what we will often say affects working memory. So the ability to kind of hold something in your head long enough to do something with it. And then orientation, which I sort of talked about, is often affected by Alzheimer's disease. The next thing that I will do if someone scores below in a concerning range, so maybe below average for someone's age, is do a CAT scan or an MRI of the brain. And I think one of the things that's really important to know is that an MRI or a CAT scan doesn't give a diagnosis of Alzheimer's disease. One can't look at an MRI and say, "Oh, there's Alzheimer's disease." What it does is give additional evidence to support what we've already done, which is, what is the story of one's function and one's thinking? What does the cognitive testing show? And then when we look at the brain, does it show things, particularly sort of brain loss or brain shrinkage in particular areas that might be concerning for Alzheimer's disease versus something else? So there are areas of the brain that are concerning for Alzheimer's disease, whether or not that's on the surface of the brain, whether or not that's in the middle of what we call the ventricles, or in the hippocampus, which is a real important place to where memories are often thought to begin. And then once we make a diagnosis, then we turn to treatment. And there are, for most of my 20 years, treating people with memory disorders, there have been a couple medications for Alzheimer's disease. And there's what we call acetylcholinesterase inhibitors. So things like donepezil, or the trade name Aricept, which you may have heard about, and some sister compounds. And what these medications are designed to do are just actually these medications and the other family, which is represented here by memantine, is to try to increase the amount of neurotransmitter that's sort of floating around in the brain, right? So you can imagine that if you're starting to lose brain cells, and the currency of the brain are what are neurotransmitters, then you either want well, in an ideal world, you'd stop the brain from losing those cells. But if you can't stop the process of the brain cells dying, then the least you can do is try to sort of replace the currency and sort of fill up the brain with those neurotransmitters. And that's what these medications do. And so they've been, this is sort of has been for 20 years standard of care in treating Alzheimer's disease. And we think that it may slow or maybe delay the progression of the disease, sort of, or of the symptoms, not the disease itself, right? Because it's not saving the brain cells; it's just helping the milieu of the brain function better. But now the story I've been telling is sort of a depressing one to this point, and this has sort of been the story of my career for a lot up until maybe the last few years, when there have been some remarkable advances in our understanding of if not the ground truth of what causes Alzheimer's disease, but certainly we now know what some of the molecular pathways are in Alzheimer's disease, and have developed ways to detect that and start to treat it. And so now I'm going to sort of shift a little bit to sort of talking about that. So at the very early part of the talk, I showed that curve of amyloid and tau, those proteins that were sort of accumulating in the brain even before we started to develop symptoms. And now we've found ways to test for those. It used to be that the only way that you could confirm that someone had Alzheimer's disease was you'd have to wait until they had passed and do an autopsy on their brain and look for these hallmarks. And now we can test for these things while people are alive. And this is revolutionary. And until right now, there are two ways of finding those biomarkers and testing for them. One is what you see on the left side, which is this specialized PET scan. So this is different than the PET scan you might get that you might get for most conditions in medicine. This is a specialized PET scan that uses a marker that goes and attaches to either the amyloid in the brain or to the tau protein in the brain, and then you do a PET scan, and this tells you gives you a representation of how much of that amyloid is there, where it's at, how much of that tau is there, where it's at. It's only been, I think, within the last year that these scans have been approved by Medicare for payment. So for the last 10 years or so, even longer, they were almost solely the domain of research. And so now these are becoming part of clinical practice. The other way to check for these biomarkers is by looking at the fluid that surrounds the brain, right? Because these fluids sort of leak out of the brain, and if you can then look at the fluid, you can see those proteins in the fluid. And so the way to get at that fluid has been through spinal taps or lumbar punctures, and now the reason why this is so important is that if you can test for these proteins, you can then develop therapies that target these proteins. I put the word blood there with a question mark, which is that there's a lot of excitement about the possibility of blood tests for both amyloid and tau, and it's these blood tests aren't FDA approved yet, but there's a lot of effort going in to see if we can develop blood tests, and then so not have to put people through a PET scan or a spinal tap. So about 2 years ago, there was a lot of controversy because this first medication for targeting amyloid was given a kind of a conditional approval by the FDA, despite not great evidence for its efficacy. So there were two big studies. One of them didn't show. One of them showed that you could reduce amyloid, by giving this monoclonal antibody. But it only showed at a really high dose and in only one of these studies. So it wasn't clear whether or not. So there was some of the advisory on the advisory board for the FDA recommended against approval, and some of them recommended for approval, but it went through. But it was a sort of a conditional approval, and there were all kinds of barriers to patients actually getting that medication. More recently, within the last year, 18 months, the second medication in this family was approved, and it's lecanemab, and this is the one that is now being prescribed. And this came out of a study of about 1,800 patients, looked at people over about a year and a half, and they would come into the study and get an IV and get the medication through the IV twice a month. And what it showed at the end of those 18 months, the year and a half, was that people who were compared to placebo, people who got lecanemab had a 25%, 27% difference in their decline. So they decline less than placebo. Unfortunately, there are, every medication, as we all know, every medication has its side effects, and there were some significant side effects to these medications that came out of not just this trial, but all of the previous trials with these sorts of medications. One of them is an infusion reaction, so people can have kind of a rare anaphylactic reaction to these medications. Less so just kind of feeling flu-like, and so about a quarter of people would have those effects. And then the thing that's received a lot more attention is that in a not insignificant number of people in these trials, these trials almost always involve brain imaging, MRIs, to sort of look at how the brain changes over the course of a study. And one of the things they found was that 17% or 12.5% would either have little tiny areas of bleeding in the brain, or they'd have areas of brain swelling. And oftentimes these were asymptomatic. People didn't even know that they were experiencing these, but sometimes they did have symptoms, and sometimes they were significant. And so this got, because this was sort of because of the benefits of the drug, this got approved last summer. And here's some of the data on it, and it's pretty impressive that if you look for amyloid on PET scans in people who were in the placebo group versus the people who got this drug, their amyloid just plummets. So you almost can't see it. And they're doing cognitive testing in individuals who were in the trial, and the people who were getting the drug clearly did better from a cognitive standpoint than people in the placebo. As you can imagine, this has spurred a lot of research interest, and there are other medications that are sort of currently being that are in the pipeline. I wanted to point out this one, which is not FDA approved, but I think it's going to be before the FDA here relatively soon. And it has shown similar sorts of benefits and similar sorts of effects to lecanemab. The advantage is that it only gets dosed once a month, so you only have to come in once a month for this. So that is a nice change. And again, the cognitive benefits have been pretty convincing. So this is a picture of those little tiny hemorrhages, the microhemorrhages, or the brain swelling, and so because of these, if one gets this medication, MRIs become really important. So you get one before you get prescribed this drug. You get You get about 4 within the first year or so to sort of monitor to make sure that you're not having any of these changes. Um, so, um, so not only are you going in once, either once a month or twice a month, but you also have to factor in going in to get imaging um, relatively regularly, or if you ever have symptoms. That's kind of how we would evaluate that. So, given that there were no new medications that sort of made their way to FDA approval almost for 20 years, the fact that we now have two new ones is a remarkable advance, I think. But there are lots of open questions. So one of them is that there was underrepresentation of Blacks, Native Americans, Hispanics in these trials, despite a recognition while they were running the trials that this was a problem. They had a difficult time recruiting. It's not clear, there, as we sort of talked about all the different risk factors for Alzheimer's disease, it's not clear if how these therapies are going to interact with people who have a history of high blood pressure or not, history of high cholesterol or not, and the other risk factors. It's sort of too early to tell whether or not if you have one of these risk factors, these medications are going to be good for you. They're going to work for you, or maybe they're not going to work for you. Sort of an open question. And these medications are all these trials were only for mild cognitive impairment, which, remember, is people who it's not even clear they have any change in their daily function, or for or for the mild stage of Alzheimer's disease. So these aren't medications that got FDA approved for moderate or severe Alzheimer's disease, and so we don't know whether or not they're going to be helpful at more advanced stages. The second point here is, how meaningful is this change, right? So those graphs are pretty remarkable from my standpoint, because they do show a real change. But you can also the other way to interpret that is people are still declining a significant amount even with the drug. And so if taking this drug requires you to come in to a clinic, a hospital, right, twice a month, and get these MRIs, how meaningful is that change? And I think it's going to be really individual to different people and different families. There's also an open question about how long, how these medications are going to be used. So, are you going to be on this medication forever, right? Or are you going to? There's some evidence from the donanemab trial that maybe you give the medication, you clear out all the amyloid, you do another scan, you prove that the amyloid level is pretty low, and then you take someone off of the drug, and then you check again for amyloid sometime later. And so maybe it's something you just kind of go in for your fix up, right, to sort of clear out your amyloid. We don't know if that works. We don't know if that's going to be the future of these medications or not. And I think if we look back to those early figures I showed of that asymptomatic stage, that preclinical stage, it raises the question of, if we're accumulating amyloid for 10 or 20 years before we ever become symptomatic, do you start to think about using these drugs for people who don't have any symptoms? And there are ongoing trials now for enrolling people who have proven to have amyloid in their brains but don't have any cognitive symptoms. And so I think that's going to be an important part of the story that starts to emerge in the next 5 years. I wanted to just sort of there's a lot of stuff on the slide, but I just wanted to sort of recognize that this talk has been mostly focused on the cognitive symptoms, but as we all know, some of the hardest things to deal with are some of the behavioral symptoms that go along with dementia, right? Whether or not that's depression, hallucinations, paranoia, delusions, um, agitation, what we might call sundowning, right? These are the things that become really disruptive to the person who's experiencing these symptoms, but often to family. And as sort of an approach, what I try to do is look for whether or not there are things that might be sort of setting these behaviors off, whether or not there are medications, things like um, um, certain incontinence medications, certain Benadryl, for instance, whether or not someone has a urinary tract infection or a budding pneumonia, or um, these sorts of things can sort of set off some of these behavioral symptoms. Um, Whether or not someone's having pain but can't sort of verbalize or recognize kind of where that pain is coming from, can sometimes set off these symptoms. And then just changes in routine, right? You've lived in a house for 40 years, and then you suddenly move to a new house, a new setting, and that can be really that can sort of take someone out of their routine, where routine is really important for people who have memory problems. I think we try not to start with medications as a way to sort of deal with behavioral symptoms. We really now try to focus on environmental changes, right? Or can you figure out what is it that is sets off this agitation? Is it particular kinds of conversations I have with my loved one? Is it a particular time of day? Is it around some particular subject, right? And maybe there's a way to sort of change the environment, change the way I interact with my loved one that reduces the chances of some of those behaviors. And then there are sometimes medications that we turn to because environmental changes just aren't sufficient. And so, some of those are antidepressants or anti-anxiety medications. And then, as generally as from my view, and I think this is kind of the emerging view in the field, is we really turn to antipsychotic medications as sort of a last resort. But sometimes we need that as a way to sort of treat really bad paranoia, really bad hallucinations, really bad agitation. But those come with significant risks. So the atypical antipsychotics have risks for heart attack and stroke that are real. So, all right. So in the last few minutes, I just wanted to talk a little bit about prevention of Alzheimer's, and part of the challenge here is that doing studies on prevention of dementia is really difficult because let's say you want to know whether or not exercising in your 40s will be a benefit to delaying or preventing Alzheimer's disease when you're 80. How do you design that kind of study, right? Are you gonna follow people for 40 years? How much would that cost, right? How many people would you have to enroll in that? So most of the data we have from these are epidemiologic studies. So just looking back at data that's available on what things might have affected or not affected one's development of Alzheimer's disease. So one of the things that we found is that people with high educational attainment tend to have a reduced risk of Alzheimer's disease, and it's hard to know exactly why that is, because it's hard to sort of isolate someone's high educational attainment from other factors, but whether or not that's their socioeconomic status, the kinds of stresses that they've experienced in their life. But it's clear that this is a risk factor, and there is some evidence that people who engage in cognitive activities as they get older, whether or not that's learning a new instrument or learning a new language, or it used to be we talked about doing crossword puzzles, that there is a preventative benefit to doing sort of that. And it's hard to know exactly why that is. Um, I think there's sort of a theme as I kind of go through some of the prevention strategies, is that I think what you want is to engage in cognitive activities that take you out of your comfort zone, that make you work a little bit, but that aren't so difficult that you stop doing them or get frustrated. And it's a hard thing to find that balance. Um, um, the probably the most common or the most important modifiable factor is exercise. So so doing, maybe 150 minutes of some exercise during the week is is protective for Alzheimer's disease. Um, and this is particularly important in midlife. But the benefits have been shown um, sort of throughout life. Um, I mentioned earlier about the importance of sleep. So we think sleep is people who have really poor sleep or don't get enough sleep are at increased risk of Alzheimer's disease, maybe 3 or 4 times the risk. And there's probably different uh, reasons for this, right? Part of it is people who have, for instance, sleep apnea aren't their oxygen levels sort of dip during sleep, and they're probably oxygenating their brain less than they should. There's an association with sleep apnea and high blood pressure, and we sort of have seen how high blood pressure is an independent risk for Alzheimer's disease. And lastly, sleep is that time, particularly if you get kind of can go through all the stages of sleep. It's where your brain sort of clears out the garbage that was collected during the day. And so there's evidence that that sleep is important for clearing some of that amyloid that might accumulate during the day and consolidating memory. So so it ends up being really important to pay attention to sleep. And then hearing loss. Again, this is kind of a more recent story that people who have hearing loss and don't get hearing aids have a significant risk of Alzheimer's disease. So so this has sort of re-energized the field to start paying attention to the different kinds of sensory input that people with Alzheimer's disease or people who are getting older might need. And so just to sort of summarize here, so it's if I were to there's lots of research out there, lots of studies that sort of point at having some benefits of this or some benefits of that. But these are sort of the factors that there's most evidence behind. So doing some regular physical activity, paying attention to treating depression if that's an issue, getting your hearing evaluated, getting a sleep study, doing some sort of social activity. So again, social isolation is bad and is a risk factor for Alzheimer's disease. Moderate alcohol use, if any, which is maybe there's controversy about this, but maybe one or two drinks a day at most. Aggressively treating diabetes, high blood pressure, cholesterol. These are all the things that we recommend. So I think I'll stop there and take some questions.